PrepLadder brings you FMGE PYQs High Yield Edition. In this series, you will get questions from previous FMGE exams as a quiz with 5 seconds to answer each question before the correct answer is revealed. As a cherry on top, there is a brief explanation of that topic too. Keep us updated on your progress by commenting how many questions you got right. First question on your screen now.
Question 1. A cancer patient undergoing radiotherapy is given a dose of 1.8 to 2 g once daily for 5 days per week for a duration of 6 to 8 weeks. What is this type of brachytherapy called? Here are the options. A. Regular fractionated radiotherapy. B. Hyperfractionated radiotherapy. C. Accelerated fractionation radiotherapy. D. None of the above. And the correct answer is option A. Regular fractionated radiotherapy. Here's the explanation.
Now, when we are giving radiotherapy to a patient, let's say a patient is needing, let's say that the patient is needing X amount, X gray of radiation for treatment. We can either give it as one single high dose therapy or we can give it in fractions. What are the advantages of fractionated radiotherapy? So, fractionated radiotherapy explores the benefits of the 4 hours, 5 hours, 6 hours of radiobiology. So, first let us see what are the 6 hours. 6 is the new one that has been added, which is the 4 one. We have reoxygenation, repopulation, repair, redistribution. This was the 5th one, that was radiosensitivity. And then we had the have the 6th one, that is reactivation of the immune response. So 6 hours of radiobiology are the 6 hours. And how does fractionated radiotherapy explores this? So now let's say that first one is the repair. If you give entire X amount of radiation in one single dose, right? It will kill the tumor cells, but it will kill the normal cells also with the high dose. When you give a lesser dose in fraction, right? So you are giving lesser dose, so the normal cells will not be killed, even if they are damaged. So when you are giving fraction, you give one fraction on Monday, one fraction on Tuesday, right? So the normal cells, even if they are damaged on Monday, they can get repaired. Okay, their repair mechanism is intact. So this is the repair of the sublethal damage that can happen in the normal cells. So the normal cells killed are decreased. So in the standard fractionated therapy, we give the fraction of radiotherapy for 5 days of the week. एक fraction देते हैं, 1 fraction per day, and then the weekend is off. Okay, then the weekend is off. So repair is the advantage here.
Question 2. What diagnosis can be derived from the image given below? Here are the options. A. Multiple myeloma. B. Ankylosing spondylitis. C. Pyogenic spondylitis. D. Pott's spine. And the correct answer is option D, Pott's spine. Here's the explanation.
This is the abnormal area that we are seeing here. It is not just one vertebra, there are 2 vertebrae involved with the intervertebral disc also gone here. Right, more than even 2 vertebrae involved. This is the 1 vertebra, the 2nd vertebra and the 3rd vertebra. Right, so and that means the intervertebral disc is also involved. Intervertebral disc is involved. Whenever you have intervertebral disc also involved, with the formation of collection abscess like this, think of TB spine, that is called as Pott's spine, because the most common type of TB is paradiscal TB. Okay, the most common type is the paradiscal TB. So intervertebral disc involving the adjacent vertebra. So Pott's spine. Look at how the abscess formed can compress the spinal cord, and that is why it can lead to paraplegia as well. So for the evaluation of Pott's spine, MRI is the investigation of choice because it will help you have a look at the spinal cord as well. So whenever you want to see spinal cord, MRI is the investigation of choice, like in a case of traumatic paraplegia also. Paraplegia means the involvement of the spinal cord, so MRI would be the investigation of choice.
Question 3. What does the following X-ray depict? Here are the options. A. Emphysema. B. Tension pneumothorax. C. Pleural effusion. D. Bronchiectasis. And the correct answer is option C, pleural effusion. Here's the explanation.
Now going on to the next pathology, that is pleural effusion, another pleural pathology. So for pleural effusion, if the question is, what is the most sensitive investigation? Because pleural effusion is fluid containing pathology, so it is going to be ultrasound, right? If the question is, what is the most sensitive chest x-ray view? We have seen it is the same side lateral decubitus, ipsilateral, lateral decubitus with horizontal beam or vertical beam. It is the horizontal beam. That's the most sensitive. After that, the next comes is the lateral erect, which is the least sensitive. The chest x-ray PA erect is the least sensitive, right? USD can pick up as less as 5 ml of fluid in the pleural cavity as well. It is the most sensitive. Okay. So now pleural effusion clinically would give a dull note. Fluid gives dull note, pneumothorax gives hyperresonant note. In the PA view, what is the first sign that we see in pleural effusion? So the fluid starts accumulating in the dependent part. The dependent part is the costophrenic angle. So the first is the blunting of the costophrenic angle. Okay, the first is the blunting of the costophrenic angle. So look at this one. This is the costo, this is the phrenic part. The angle is sharp. If there is accumulation of fluid here in the costophrenic angle, then the angle becomes blunted. So what do we see here? The angle is blunted. You don't see the sharp angle. So this is the blunting of the CP angle. Remember, the CP is the costophrenic. It's not cardiophrenic. So this is the blunting of the costophrenic angle. That's the first thing that we see. Now when more fluid accumulates, the fluid goes up. Classically, this pleural effusion has the meniscus sign or the Ellis-S curve. It's not the horizontal level that we would see, right? So what do you see with pleural effusion is the fluid level goes like this. Okay, the lateral side is more up. Okay, the lateral side is more up. So you would see it like a meniscus, or this is called as Ellis-S curve. Okay, that's the Ellis-S curve which is seen in pleural effusion. Now if I ask you why this is not hydropneumothorax, because in hydro means water, pneumo means air. So it's air and fluid both. Whenever air and fluid are present together, the air fluid level, air above, fluid below, it is a horizontal level. Imagine like the air giving the pressure on the fluid, it makes it horizontal. So the air fluid level is always horizontal. So hydropneumothorax, HPT hydropneumothorax is going to have this horizontal level rather than the Ellis-S curve, the air above, the fluid below. Okay, so that is how you differentiate. Now, do you see the pleural effusion in this image? Right side or left side? It's the left side. The right side angle is sharp and you see the blunting of the angle on the left side. So this is left pleural effusion. So always check the costophrenic angles in a chest x-ray, right? Now, going on to the next one. What do you think is the cause of the whiteout hemithorax in this patient? The right side, consolidation, collapse, pleural effusion. Because the trachea is shifted to the opposite side, there is blunting, there is no air bronchogram sign. All of this tells you that this is right pleural effusion, right? There is blunting, opposite shift. There is no air bronchogram sign. It's black. So this is the right pleural effusion. Okay, this is right pleural effusion. This one here, remember, just to add on, this is not pneumoperitoneum. This is the normal fundic bubble that we are seeing. The gas, the air in the fundus of the stomach, that is the normal fundic bubble that we are seeing on the left side.
Question 4. Identify the heart chamber marked in the given CT image. Here are the options. A. Right atrium. B. Right ventricle. C. Left ventricle. D. Left atrium. And the correct answer is option D, left atrium. Here's the explanation.
Coming to how do you identify the heart chambers and the various vessels on the CT and MRI. This is a previously asked question in one of the recent exams. So this is very, very important. Now, so first of all, this is a CT scan. because we see the white bone. So this is the CT scan. And what do we see in the CT? This is the heart. Is the heart normally placed? Yes, it is facing, the apex is going towards the left side. Your right, that is left. So this is a normally placed heart. Now, how do we identify the chambers here? Behind the sternum, we had seen in the lateral chest radiograph, we have the chamber of the heart, which is the right ventricle behind the sternum, right? Behind the sternum, we have the right ventricle. So that is the anterior most chamber of the heart that we are seeing. This is the midline of the heart, right? So the heart is located like this. This is the midline of the heart. So whatever is to your left side is actually the right side of patient. Whatever is your right side is the left side. So these chambers here, this is the right ventricle. So this is right atrium. This is left ventricle. This is left atrium, right? So right ventricle ke baaju mein, this is going to be right atrium. This is going to be left ventricle. This is going to be left atrium. Which is the posterior most chamber of the heart, like you can see here. Just in front of the vertebra, we have the left atrium, which is the posterior most chamber of the heart, right? The left atrium is the posterior most chamber of the heart, and the right ventricle is the anterior most chamber of the heart. Now, what are we seeing here? The rest of the relations, the structures here. This structure which is draining into the left atrium, that is going to be pulmonary vein. The pulmonary vein drains into the left atrium. This is right side, this is left side. This one adjacent to the vertebra. This is the aorta. What part of the aorta? This is the descending aorta, because descending aorta is present in the posterior mediastinum. So that's the descending aorta. And here behind the left atrium, this is where we would have the esophagus that would be located. So esophagus ke baaju mein left atrium and aorta. So remember we said transesophageal echo is done for left atrium to look for left atrial thrombus and for aortic pathologies like aortic dissection.
Question 5. In which condition is popcorn calcification seen? Here are the options. A. Hodgkin's lymphoma. B. Pulmonary hematoma. C. Metastasis. D. Fungal ball. And the correct answer is option B, pulmonary hematoma. Here's the explanation.
One very, very important calcification that I want to talk here is this popcorn calcification. Okay, that is the popcorn calcification asked in one of the recent FMGE exams. Now, popcorn calcification in the lung is seen in pulmonary hamartoma. Okay, it is seen in pulmonary hamartoma. So imagine, like, you can remember as hamara tomara popcorn, right? Sharing the popcorn in the movie, hamara tomara popcorn. Hamartoma gives the popcorn calcification, that is chunky calcification. So this is the lung lesion with this chunky calcification, that is the popcorn calcification. A lesion with the popcorn calcification, it is hamartoma.
Question 6. Identify the investigation shown below, which is used for the evaluation of distal bowel tumors. Here are the options. A. Enteroclysis. B. Barium meal. C. Barium meal follow-through. D. Barium enema. And the correct answer is option A. Enteroclysis. Here's the explanation.
Now, what is enteroclysis? Enteroclysis, as the term says, entero is the small intestine, like we have gastroenteritis, small intestine. So, enteroclysis is the study of the small intestine, but the difference as compared to BMFT is, in BMFT, we give the barium orally. In enteroclysis, it is like small bowel enema. The contrast is given directly into the small bowel by putting the tube. We put the nasojejunal tube and directly it goes into the jejunum. So what will you see is, you will see the tube like this in enteroclysis. That is how you will differentiate from BMFT, right? You will not see the barium in the stomach.
Question 7. Which of the following MRI imaging techniques is shown in the image below? Here are the options. A. T1 MRI. B. T2 MRI. C. Stir. D. Flare. And the correct answer is option B, T2 MRI. Here's the explanation.
So now we said that based on the appearances of the substances in these various sequences, we get to know whether it's CSF, whether it's fat, whether it is white matter. So for example, if you see here, if the water is white, right? So look at this T2 weighted image. CSF is white on T2 weighted image. It is dark on T1. There's another sequence flare where it is dark. So remember that T2 weighted water is white on T2. So you remember this as WW2, that is water white on T2, that is World War II, water white on T2. Next, what we have is white matter is light. That means it is white on a T1 weighted MRI. I'll tell you the tricks to remember that when we see the images as well. So based on these appearances, basically we get to know the substance. Remember that fat is the substance which is bright on MRI, be it T1, light means here bright but less bright. So T1, T2, which is the substance which is white on both T1 and T2? It is fat. Okay, it is fat which is bright, which is white, hyper intense on both T1 and T2. Now, how do we identify first whether it is CT or it is MRI? Then how do we identify the MRI sequences? Always look at the bone, and to be very specific, always look at the bone cortex. So in this image, you see that it's a white bone. If it is the white bone, we know that it is CT scan. Look at this image. Do not get confused by the outer white line. That represents the fat. Okay, that is the fat which is appearing, the scalp fat which is appearing white. We said that fat is white on MRI unless it is a fat suppressed MRI sequence. So where do we locate the bone here in this image? So what you should be looking at is just outside this brain parenchyma, this black line that we see. So this black line just outside the brain parenchyma, that is the bone cortex. Okay, so this is the bone cortex which is black. Look at this one. This is the inner table of the skull. This is the outer table of the skull which is appearing black. Beech mein the white that is appearing, that is basically the marrow fat that we are seeing. Okay, that's the fat which is appearing white. So the bone cortex is appearing black. So this is a CT image and this is MRI image.
Question 8. A 36-year-old farmer came to the clinic with a cough, chest pain for 1 week, and fatigue for a month. His chest X-ray is shown below. Which of the following is the most likely diagnosis? Here are the options. A. Hydatid cyst. B. Anthrax. C. Silicosis. D. Bisonosis. And the correct answer is option A. Hydatid cyst. Here's the explanation.
Now going on to the next infection, that is hydatid cyst caused by Echinococcus granulosus, and hydatid cyst can occur in the liver, it can occur in the spleen, it can occur in the lung. The differentiating point is in the lung, the hydatid cyst does not calcify. Okay, it does not calcify in the lung. Why? Because the lung is continuously moving with the breathing, so it does not allow the calcium to get deposited. So remember, lung is the site where hydatid does not calcify. So some of the signs that you might see with hydatid cyst in the chest radiograph. First one, you could see a cyst that is filled with fluid, so it will appear white. So it can appear like a spherical cyst. The next then we have is the cyst might contain some amount of air. If it ruptures, then we can see this meniscus, the air meniscus, the meniscus sign. Next very important sign and frequently asked in hydatid, that is the water lily sign. So with the rupture of the membranes, the fluid coming down, and over the fluid there are those ruptured membranes which are floating. So over this water we have the membranes floating. This is called as water lily sign. So water lily sign is air fluid level with the water lily floating. Those are the membranes floating. Other sign are the rising sun sign. You might see this serpent sign, the ruptured membranes looking like the serpent, and the other sign is the Cumbo sign. So remember these signs, and hydatid water lily is very, very important. So what is this image showing here? So this image is showing this lesion in the lung having the black air above, the fluid below. This is the air fluid level that we are seeing. And if you see carefully, overlying the fluid, there is something which is floating. So that tells me that this is the water lily sign. Okay, this is the water lily sign. If it was just the air fluid level without the water lily, then the first differential that we would have put is the lung abscess. Okay, that's the lung abscess, air fluid without water lily sign.
Question 9. A 51-year-old man complains of abdominal pain and blood-stained stools. The barium enema study of his intestines shows the following finding. What is the most likely diagnosis? Here are the options. A. Intussusception. B. Volvulus. C. Diverticulitis. D. Ulcerative colitis. And the correct answer is option A. Intussusception. Here's the explanation.
Now, what is intussusception? Intussusception is one bowel going inside another bowel, that is telescoping of the bowel is what we see. So, it is telescoping of the bowel, one bowel going inside other. Intussusception is common in a child, weaning age group where there is Peyer's patches, the lymphoid hyperplasia, which acts as a lead point for the intussusception, right? So, what do we see here is this one bowel is going inside the other bowel. The outer one is called as intersuscipiens. Even that sounds confusing, which is intussusceptum and intersuscipiens. So remember that the outer one is the recipient. So that is intersuscipiens. The inner one is the intersusceptum. The one which is going inside is the intersusceptum. Now, what is the investigation of choice for intersusception? Especially in a child, it is ultrasound, right? No radiation. It helps you identify the bowel within bowel appearance. That is the target sign or the donut sign is what we would see on ultrasound. In adults, visualizing that might be difficult. So, CT scan can be used in adults. Barium enema used to be the gold standard previously, and intussusception is a condition where barium enema actually can be both diagnostic and therapeutic. So, in which condition barium enema is both diagnostic and therapeutic? It is intussusception. So, what are the signs that we see in barium enema? The sign that we see in barium enema, the barium going up. When the barium goes up, reaches the point of intussusception, the barium goes around the intersusceptum like a claw, right? So, the barium spreads out like a claw. So, this is called as claw sign. Okay, we get the claw sign. So, we get the claw sign in intussusception on barium enema. Other sign that has also been asked is the coiled spring sign. What is the coiled spring sign? Intersusceptum, intersuscipiens, there's some space. If there's some space, the barium will go outlining the intersusceptum. So that gives the coiled spring sign. You will see the barium like a coiled spring appearance. Okay.
Question 10. A 33-year-old female with fever, weight loss, and elevated levels of ACE levels presented with a chest X-ray as below. What is the probable diagnosis? Here are the options. A. TB. B. Sarcoidosis. C. Silicosis. D. Small cell cancer. And the correct answer is option B. Sarcoidosis. Here's the explanation.
Sarcoidosis. Now, sarcoidosis, generally the history that you would have, it has associated hypercalcemia. It has high levels of ACE enzyme as well. And very, very important, given in the recent exam, it is bilateral hilar lymphadenopathy that it presents with first. Okay. So, bilateral hilar lymph nodes are seen with sarcoidosis, and then the lung parenchyma is also involved. And then in the last stage, it leads to the lung fibrosis as well. So, sarcoidosis, most important, bilateral hilar lymph nodes. So, like you see here, the hilar lymph nodes, the rounded opacities making the hilum bulky. Plus, along with that, this is the trachea, and you see the right paratracheal lymph node as well. So, you have three groups of lymph nodes, the right paratracheal, the right hilar, the left hilar. So, this is 1, 2, 3. So, this is called as 1, 2, 3 sign, right? This is like a garland of lymph nodes, also called as the Garland sign, which is actually the name of the person who gave this sign. 1, 2, 3 sign or the Garland sign, also called as pawnbroker sign, is what we have in sarcoidosis. The bilateral hilar lymph nodes is very, very important.
Question 11. A 10-year-old girl presents to the OPD with a back deformity. What is the likely cause? Here are the options. A. Congenital. B. NF1. C. Idiopathic. D. Neuromuscular. And the correct answer is option A. Congenital. Here's the explanation.
Next, again, one of the recent asked questions. So, what kind of scoliosis is this? How do I know it's a scoliosis? By the bending of the spine. The lateral bending of the spine is scoliosis, right? So, what angle do we use in scoliosis first? So, remember in scoliosis, CO, we have Cobb's angle. Cobb's angle is used to measure the degree of scoliosis. How do we measure the Cobb's angle? So, this is the scoliosis, right? The curvature, the uppermost part and the lowermost part. So, we take a line across the vertebra here, right? Upper wale vertebra ka upper border, lower wala vertebra lower border, and we join those two lines and we measure the angle. Or we can take perpendicular line to this, and this angle is basically the Cobb's angle. So, if you get an image like this, what angle is being measured? It's the Cobb's angle. And the question asked in one of the exam was, what kind of scoliosis it is? It can be physiological, pathological. In pathological, it can be congenital. So, how do you identify congenital scoliosis? Is when you have vertebral anomalies associated with the scoliosis. So, in the scoliosis, I see that at this level, there is just one half of the vertebra that has developed, the other half has not developed. So, when I have vertebral anomalies associated, like hemivertebra, it is suggestive of congenital scoliosis because it's a congenital problem, embryological development problem. So, it is congenital scoliosis.
Question 12. Comment on the diagnosis of the CT chest shown below. Here are the options. A. Aortic dissection. B. Pulmonary embolism. C. Cardiac myxoma. D. Aortic aneurysm. And the correct answer is option A. Aortic dissection. Here's the explanation.
Now, in aortic dissection, what do you see in the imaging? In the CT scan, you see this, the black intimal flap that is dividing the aorta into two lumen, right? So, this is aortic dissection. What aorta is this? This is the ascending aorta, SAP, ascending aorta. So, this is Stanford A. The descending aorta is also involved. So, this is involving both ascending and descending aorta. This structure here is the arch of aorta, intimal flap, dissection. This is the dissection involving the arch of aorta, right? If the question is what is the most accurate investigation for aortic dissection to look for the intimal flap extent, it is MRI. But we don't do it in emergency because it takes a lot of time. So, MRI is reserved for follow-up, right? It's not used in emergency. So, that is aortic dissection. Now, how do you differentiate which is the true lumen and which is the false lumen? So, the true lumen is the one which will expand in the systole. So, when the blood is pumped into it, it will expand, while the false lumen, it will be compressed. So, if this is the aorta and this is the intimal flap that we have, the blood flowing in with great pressure, this will expand. That means this will get compressed. False lumen is generally the larger one. It is less contrast dense because the blood flow is slow. True lumen is more contrast dense. And what are the signs that help us to identify false lumen? One is the presence of the beak sign and the presence of the cobweb sign. What is the beak sign? So, look at this one. The false lumen forms this beak shape with the intimal flap, right? So, look at this one. It's a beak shape. So, it is crescent shape, right? It is the false lumen is crescent shape and the true lumen is generally round. Okay, the true lumen is round.
Question 13. A 55-year-old male patient presented with complaints of dyspnea with congestive heart failure. The clinician wants to know whether his heart failure is with preserved ejection fraction or reduced ejection fraction. Which of the below investigations is used for the calculation of ejection fraction? Here are the options. A. Muga. B. SPECT using thallium-201. C. PET myocardial perfusion imaging. D. Systemic scan with pharmacological stress. And the correct answer is option A, Muga. Here's the explanation.
For ventricular function, the nuclear scan that we use is the Muga scan, multiple gated acquisition. We use radio-labeled RBCs in the Muga scan. So, ventricular function basically means the ejection fraction. The function of the left ventricle is to eject the blood. So, ejection fraction, this is by Muga scan. So, Muga scan is also called as nuclear ventriculography because it's a nuclear scan which helps us evaluate the ventricular function.
Question 14. A 45-year-old female presents with a complaint of abdominal pain and fever for the past 3 days. She localizes the pain to her epigastric area and states it radiates to her right upper quadrant. She notes that it became markedly worse after eating dinner last night. Her past medical history is significant for hypertension and hypercholesterolemia. On abdominal examination, inspiratory arrest is noted on deep palpation of the right hypochondrium. Which of the following is the investigation of choice for this condition? Here are the options. A. HIDA scan. B. USG. C. CT scan. D. Biopsy. And the correct answer is option B, USG. Here's the explanation.
So, what are the findings in acute cholecystitis or ultrasound? The investigation of choice here is ultrasound for acute cholecystitis. First of all, what would the patient present with? The patient would present with acute right hypochondriac pain associated with vomiting. And what sign is positive? It is Murphy's positive. Okay, it is Murphy's positive.
Question 15. What is marked by an arrow? Here are the options. A. Right atrium. B. Pulmonary trunk. C. Aortic knuckle. D. Superior vena cava. And the correct answer is option C, aortic knuckle. Here's the explanation.
So, quickly revising here the anatomy here, this is going to be the right atrium. This is going to be the left ventricle. This is the cardiophrenic angle right side, left cardiophrenic angle, costophrenic angle. This is the aortic knuckle. Then we have the pulmonary trunk and then we have the left atrial appendage. These on the left side, these are called as the moguls, right? Those bumps coming on the left side, aortic knob first mogul, pulmonary second, left atrial appendage third, left ventricle fourth, and the fat here in the left cardiophrenic angle, that is the fifth mogul on the left heart.
Are you able to cope up with the PYQs? Next up is anatomy from the FMGE Recall Rush. Help us reach more aspirants by dropping a like. Join the best community of doctors by subscribing if you are new here. See you tomorrow.